We have 2 minutes or 3 minutes for a couple of questions. So I hate to leave that without giving anybody an opportunity to challenge anything you said, so please stand up for a second. Please.
Hi, Jessica from the California Department of Public Health. Thank you so much for your overview. I am mainly interested in the IOM report from 2 years ago that you said really clearly articulated how EHRs could pick up those social determinant of health indicators or elements. And I was wondering, to your knowledge, has anybody adapted that? And how has that incorporation in their health system improved outcomes for that patient population?
You know, I don't know how we're doing on adoptions of it. I can refer you to the report, and all the IOM reports are downloadable and they're free. And this one was a particularly good one. We sponsored the committee from my office at NIH. That was an exceptionally good committee, and it's a very evidence-based report. So everything that they recommended was linked to the epidemiology, and they also looked at the validity and reliability of the measures and the practicality of the measures. So I think it has remarkably good potential. And again, you know, if you just take something like cigarette smoking, so who doesn't have about cigarette smoking? Now, it turns out that one recent study showed that, probably not in your organizations, but using the data from the medical expenditure panel survey, only about 50% of smokers say that they've been advised by their physician in the last 2 years to stop smoking. And when this committee looked at the question on smoking, it turns out that question is not asked in a standardized way, it's not always recorded, and so forth. So, and then, you know, demographic factors do matter, and that even though we don't know exactly what to do with that information, starting to record it provides a database to study these things in more detail. No, Arnie, do you know if the uptake is going?
I think a number of delivery systems that are at the more progressive edge have begun to ask for this, and I know that the ONC has been actively, I think they are considering building this into meaningful use for as long as the meaningful use program is.
Just to add what Arnie just said in response to your question, they are building that into the ONC, into the MACRA and the payment, et cetera. But also, ARC has funded 3 national centers to look at this issue. And Berkeley, Dartmouth, we're one, and we'll be fielding a national survey of health systems across the United States, probably early next year. And we have a section on exactly your question. Are they doing this at what level? What are the barriers and so forth? And the companion centers will also be looking at some of those issues. So perhaps 6 months, 9 months from now, we'll have more information on that. But like Arnie, I know of half a dozen or so organizations that are experimenting with best how to do this.
Let me take one more there and then move on.
Follow on to prepare project PARE from the National Association of Community Health Centers as an implementation toolkit to do this.
Oh, terrific. It's really good to hear. I think that the information, not only for the clinical side, but actually to start creating a research base which will help us understand how these factors affect outcome.
There's one more question here from.
It's a very narrow question about, as I look at these, I think we're all struck by the impact of education on quality adjusted life years or almost any indicator that matter to people. It brings up this question of leverage. And so one idea would be, well, just invest in a better education system in the United States. Now that's a long build, and there's been a lot of people who are working on that. Another hypothesis that might attract people who want more leverage would be to say, are there ways that one might tweak what the healthcare delivery system does to kind of try to minimize some of the adverse effects on health of low education? For example, I know some delivery systems have begun to look at sort of it's a proxy measure of people's understanding and capability to manage health, such as using so-called PAM or patient activation scores to decide how much to invest in helping people to be educated specifically with respect to the risk factors. Is there any reason to believe that the latter, which would be a much higher leverage solution, is a better or worse course than just acknowledging that we have to invest a lot more in our education system in order to harvest some of that, close that gap that appears to be so strongly there with education.
You know, I wish I had the answer to that. It's a very difficult question and a challenging one from a policy perspective. So part of it is in trying to determine what the causal pathway is between education and health outcome, and whether or not investing in education actually would improve health outcomes because it might be a different causal pathway. I'll just give you my gut feeling. We've looked at a lot of international data. It's very hard, actually it's very hard to do, but there are studies like in England. It used to be that you could drop out of school when you were 14, and you get 15. By the way, in England, this was in the 1950s. And when you got to be 14, actually half the kids in the UK dropped out of school the first time they could. And then, so they changed the law, they made it 15. It's not a great effect, but actually you boost a variety of different outcomes by doing that. Later they changed it from 15 to 16. There are countries in the world like South Korea. South Korea had a life expectancy for women of 55 years in 1960. Now it's close to 90. And that the strongest correlate is this huge investment in public education. Similarly, Singapore is another example. And again, none of these relationships, to my most critical colleagues, you know, what's at the end of this table, I don't know if it would be persuasive in a causal sense, but I find it compelling. You know, investment in education can make a difference. So doing it through the healthcare side, I think is an interesting idea, and I wish we had the data to evaluate that.
That was a narrow focus question. So with that, we're going to move on. And it's my pleasure to introduce Hector Rodriguez, my colleague at Berkeley. Hector has bounced around the state. He was undergrad at San Diego, and then a master's at Berkeley, and then a PhD at Harvard, and then came back to UCLA, and then he was stolen from UCLA, and now he's back at Berkeley. He runs our PhD program in health policy, and he's the Henry J. Kaiser Chair in the department, and the Division of Health Policy Management. He's going to tell us a bit about the data that we see coming out from health plans. And I think it's a really good setup, the two talks that we just had and the one that we're about to have, because it really is focusing on what can we do with the system and what can we do within the health part of that system. So Hector, please.